Hello, everyone, and welcome to another series tonight. I'm looking forward to hearing our presentations. We have a really great lineup for you this evening. I should introduce myself quickly first. My name is Joe Gallagher. I am a patient volunteer with Lupus Ontario, helping out with the education board. I'm also a longtime lupus patient. Lupus nephritis, sort of the main driving force for me, and eventually led to kidney failure. And earlier this year, I had a kidney transplant, and things are going very well. So it's been a big transition. But um, as one of your hosts, I'm also happy to introduce the second one of your hosts, and that is a big thank you to Roche for our presenting sponsor for their support in putting together this education and awareness event tonight. Now, enough about us. We have an even better guest star that I'm just thrilled to introduce, and that's Dr. Amanda Steiman. She works with the UHN, and she's currently at Mount Sinai Hospital. She's a clinician in quality and innovation there. She trained in internal medicine and rheumatology at the University of Toronto after earning her MD from Western University. She also did a master's program at the Institute of Medical Science and a lupus fellowship, and in addition to all that, training in patient safety and quality improvement. Despite all that, her area of expertise is lupus, and she oversees the young adult SLE clinic over at Mount Sinai Hospital, which is must be a very big thing dealing with young patients potentially getting life-changing diagnosis. Your work must be very important. We're really grateful to you for that, and we're very lucky to have you tonight. So this is these quality improvement projects that you do, patient collaboration, treatment of rheumatic conditions. You really bring a lot to the table for us, and we're really grateful for that. Just a quick discussion or a description of what we're going to be covering tonight. She'll demystify the biologics by expanding what they are and how they function in treating disease. She'll highlight the difference between biologics and the other treatment options. Of course, most of us are familiar with those, the MMF and prednisone and whatnot, detailing how patients should prepare for their biologic treatment. So there are some things to get into there in terms of necessary tests, vaccines, potential side effects. She's an expert. She'll get us all up to speed on that. And in addition to all that, she'll compare the infusion and sub-Q methods for providing the treatment as well. So we have a lot to look forward to. It's a very new class of medications. We're all very excited. This didn't exist when I was first starting my lupus journey, so I'm very excited to hear what you have to share. Dr. Steiman, please take it away.
Thank you so much, Joe, for that very, very kind introduction. First and foremost, congratulations on your new kidney. It's wonderful news that you're thriving and doing well, and I wish you continued successes of all kinds. And so thanks again. Thank you to Lupus Ontario for having me here. It really is a pleasure to be able to share with such a vibrant, committed, interested community. And so I am going to be sharing my screen. Let me make sure that I'm doing this properly. I always worry a little bit. A thumbs up, Joe, if you can see my screen. Perfect. Great. So I am here today to talk about biologics. So it's biologics explained. And when I heard the title for this talk, sort of thought of mischief managed, you know. So this is all of the ins and outs of biologics and how they work and what they do to support us in the setting of lupus. So by way of brief disclosures, I've received some small honoraria from AstraZeneca and GSK, and I have some research funding for Pfizer for a small quality improvement initiative. So I hope that by the end of this session, what you'll take away is an appreciation of the overall approach to lupus pharmacotherapy, but especially where biologics fit into the overall therapeutic paradigm. If I did my job well, then I hope that that's the takeaway. We have to start with context, of course. And so I know that I'm preaching to a very well-informed choir here. Systemic lupus is a systemic disease. It really is characterized by multi-organ inflammation. And this is driven by the production of pathogenic antibodies, and they're directed at nucleic acids and their binding proteins. So the hallmark here, and this is where these biologics will come in, so stay tuned. The hallmark is a loss of immune self-tolerance. So you start to recognize parts of you as foreign, and therein lies the pathology behind lupus. So we know that lupus is complex. We know that it's multifactorial, and we see that patients will have a genetic predisposition. Likely many genes contribute all at the same time. There's an element of environmental factors. So we think about things like environmental stressors, classically things like UV light exposure. And then we think about other things that we call stochastic, which is basically the medical term for all sorts of other random stuff. There is a breach in self-tolerance, and this triggers the inflammatory cascade. And that's the story behind the tissue damage that we see. So there is not an exam on this, but what I wanted to do was I wanted to share briefly how these medications fit in, where they fit in. I'm not going to take too deep a dive into these slides, but these are quite contemporary. This comes from a beautiful review in the Annals of Rheumatic Diseases from last year by Mary Crow. And she basically outlines lupus pathophysiology quite beautifully, and these diagrams really help to understand where things fit in. I think that where I like to start in this diagram is with this apoptotic or necrotic cell debris. So what is that? It's when cells die and degenerate, which is a natural process for cells, and it's happening in millions of cells in our bodies at any one moment. Usually there's an effective cleanup crew. And as they get cleaned up, the body sort of accepts them, and we generate new cells, and so on. In lupus, what we find happens is that those little pieces of inside the cell that get exposed as the garbage is taken out, as it were, get recognized by our own antibodies as foreign. And that's where the trouble starts. And where that begins to trigger an immune cascade is right here. We know that right in the center here, there's toll-like receptor 7, and that's really critical to the lupus cascade, inherent to a cell type called a plasmacytoid dendritic cell. And this in turn drives churning of the type 1 interferon response. And type 1 interferons drive a very potent, important inflammatory reaction on the innate side of our immune system. And so over here, what's outlined in this slide is a number of different potential druggable targets and some medications that are used or that are trying to be developed in this context to see if they can be helpful for lupus and other disorders. And in the innate side of the immune system, Anifrolumab or Safnello is the trade name, and it's the only one, there isn't a generic yet, is one of these medications, and one that we'll take a deep dive into tonight, that really addresses this type 1 interferon half of the lupus inflammatory immune paradigm. Then we look at the other side. So we look at those antibodies, and we know that antibodies are usually good guys for us, but when they're autoantibodies, and when they're autoantibodies that go awry and recognize self as foreign and as potential threat, we run into trouble. And we know that we develop more of these B cells, we develop antibodies, and therein lies a lot of the risk of damage that accrues. For this side of the immune system, from the perspective of biologics and lupus-specific biologics that we use, Belimumab or Benlysta is the one that we're going to be taking a deep dive into. There are some other biologics that we'll spend less time on tonight, as well as small molecules that do target this side of the immune system. And this is the adaptive immune system. So it's adapting to the various stimuli that it sees. And those include JAK inhibitors, which are pills, and a new class of medications that are being used for myriad conditions with inflammation, as well as rituximab, which is a B cell depleting agent. And because B cells are the ones that generate these bad actors, these autoantibodies, you could see why that medication may also be helpful in some patients with lupus. And I will defer to the expertise of Dr. Matzos, who will be presenting afterwards, to share more about CAR T cell therapy, which is a very exciting, unique strategy that may hold significant promise in the setting of lupus. And so we will look forward to his talk next. I'm not going to say any more about that. So in a nutshell, there's this aberrance in two pathways, and both are felt to be integral to the development and persistence of the lupus phenotype. The first one being type 1 interferon response, so that's on the innate side of the immune system, and then B cells, which generate these autoantibodies that cause trouble, and that's on the adaptive side of the immune system. The lupus-specific biologics that we're going to be talking about are targeted one to each of these pathways. So Anifrolumab or Saphnelo targets the innate immune system and the interferon response there. And Belimumab or Benlysta is going to be working on the B cell side of the immune response in lupus. So does everybody need a biologic? The answer is unequivocally no. Not everybody with lupus needs a biologic. We need not always access them. So where do they fit in? Where is this roadmap? Because I think that that part can be quite challenging. And so I hope that this diagram, taken from a very recent updated EULAR guidance with respect to lupus and its management, will help to lay some of the groundwork. And so very briefly, we're looking at the various forms of treatment for non-renal, so non-kidney lupus. In terms of general measures that are important for everybody regardless, we want to think about lifestyle, we want to think about sun protection, about healthy diet, about exercise, avoiding smoking, making sure that blood pressure, lipid control, etc., is optimized so as to avoid any additional risk from a cardiovascular standpoint, and ensuring that vaccinations are up to date because of the alterations in the immune system caused not only by lupus, but by the medications that we use to treat it. And all the while, we're checking in to make sure that patients are tolerating medications well and that they're not needing to alter their regimens or skip medications because they're not feeling well because of the medications that we give. And what we want to achieve is low disease activity or remission, right? So we want for there to be very minimal, and ideally no symptoms whatsoever. We want to see that patients aren't relying on much steroid, if at all. And we work towards that goal by working through this paradigm. So we see up here that there's mild disease, moderate disease, and severe disease. And the idea is that lupus really falls along a spectrum, and with any one patient, you're treating to the most severe organ system manifestation, and then the milder manifestations will ride the coattails in terms of therapeutics. So we know that hydroxychloroquine is something that we advocate for all patients unless there's a contraindication to its use. We know that not only is it good for milder manifestations of the disease, it's also a very important flare preventer. So we know from studies that date as far back as the 1990s, which is ancient from the perspective of medical literature, that those who remained on hydroxychloroquine, even at times of disease quiescence in lupus, did better than those who came off of it when they were feeling perfectly well. And so we really feel strongly that hydroxychloroquine is an anchor for us. We know that glucocorticoids, so prednisone in oral or IV form, is a good bad drug in many ways. It can be absolutely transformational from the perspective of disease control on the one hand, but on the other, it comes with myriad side effects. And so the idea is that we use the least amount of steroid for as short a time as possible. And obviously, depending on the nature of the disease, that can take various forms and can range anywhere from a few weeks clinical course on steroid all the way to more chronic use for some patients. We then look at the more conventional disease-modifying therapies, if you will. Classically among these are mycophenolates, so that comes either as mycophenolic acid or Myfortic, or Cellcept, which is mycophenolate mofetil. Sometimes we use things like methotrexate or azathioprine. And lo and behold, as we get down below the more conventional strategies, by way of immunosuppression, we come to Belimumab and Anifrolumab as potential strategies to use, and that really go all the way from mild disease to severe disease manifestations, and can be used in conjunction with some of these medications to really bolster their efficacy and to try to achieve that remission that is sought after for each and every lupus patient. In addition to those, we think about other strategies like calcineurin inhibitors, cyclophosphamide, rituximab in the setting of more severe disease. But this is where these biologics live. They have grade A evidence, so there's strong randomized evidence behind their use. And they can be used in various forms of disease. And we'll talk a little bit about the logistics in just a couple slides. Briefly, because now you know this rubric, you see this schema for lupus nephritis, which is a unique and important therapeutic pathway that I know has been discussed by the speakers yesterday as well. We really want to make sure that we're trying to optimize kidney function and outcomes by using adjunctive treatment, making sure blood pressure is well controlled, using agents that are kidney protective, and managing other concomitant risks like risk of clot, blood sugars, etc. And really the target is to decrease the proteinuria, the active sediment, as efficiently as possible and as safely as possible. And so this therapeutic schema really doesn't look all that different, with a couple of exceptions. So we still start with hydroxychloroquine and steroid, as well as MMF, which is our short form for mycophenolate mofetil, which more conventionally can be one of either CellCept or Myfortic. We think about the more conventional strategies otherwise, including low-dose cyclophosphamide, classically the Euro-Lupus protocol, which some of you may have heard of, or azathioprine or MMF otherwise. And here is where the Belimumab comes in. So Belimumab is a class of biologic that, once again, can be used in the setting of nephritis. We really don't have the same paradigm at this point for Safnello. And then we look down the list in terms of other things that we can use or incorporate, thinking about MMF plus a calcineurin inhibitor. There's voclosporin, there's tacrolimus, and then there's high-dose cyclophosphamide or rituximab for those with very severe refractory forms. And so there's sort of a paradigm to follow. And again, not everybody needs the biologics, but it becomes an important tool in the toolkit when there's complexity and when response to conventional therapeutics is not what one hopes it will be. So what's a biologic? And I've always contended that calling it a biologic is sometimes quite frightening. It sort of sounds like something that comes out of a canister and is green and slimy and oozy. And so what does it mean? Really, at the end of the day, so a biologic disease-modifying agent is designed to specifically target parts of the immune system that are causing the disease. And they're called biologics because, number one, they're made from living cells, such as proteins or antibodies, rather than being chemically synthesized like most traditional drugs. And by contrast, if we think about the more conventional synthetic disease-modifying strategies like azathioprine or mycophenolate, those suppress the immune system more broadly. So these are targeted, and these stem from living cells initially. The lupus-specific biologics that we'll spend time on tonight are Belimumab and Anifrolumab. So Belimumab targets a protein called BLyS, or B lymphocyte stimulator. And this helps the overactive immune cells, namely the B cells, survive. And so by blocking the propensity to help with survival, Benlysta or Belimumab reduces the activity of these B cells and helps to prevent the lupus activity from going awry. And so it really helps to tampen down that inflammatory response. The second agent, Anifrolumab, is a blocker of type 1 interferon receptors, and that works through that innate half of the pathway, which interferes with the overactive immune signaling that drives inflammation in patients with lupus. So let's talk a little bit about Belimumab. So it's actually not a new drug. It was approved about 13 years ago, can be given in two forms. The first is an IV infusion. This is usually administered either in a hospital or in an outpatient clinic, probably a little bit more commonly. And there can be a loading dose that can be initiated where the first 3 doses are given every 2 weeks, and then the conventional dosing is every 4 weeks thereafter, and the dose is 10 milligrams per kilogram approximately. The more common form, I would say, is subcutaneous injection, and I think there are fewer and fewer infusion sites that are offering Belimumab, because a lot of patients tend to prefer the convenience of being able to self-inject. It takes only moments. And so many patients, at least in my practice, tend to opt for the subcutaneous route. So this is a subcutaneous injection. It can be administered in the abdomen, in the leg, in the arm, by yourself, by somebody in your household, and the dose is 200 milligrams subcutaneously weekly. So it's a stable standard dose. And at the recommended dose of 200 milligrams weekly subcutaneously, the average annual cost is a staggering $22,000 per patient. So this is a very costly medication. And so you can see that not only from the perspective of not necessarily needing the additional immunosuppression, but also just from a logistic and access standpoint, not everybody needs nor should they qualify to get this medication, because they may not need it, and if lupus is well controlled without it, and there are lots of reasons why it may not be the right medication, but in some, it's an excellent tool. So who qualifies? And there's a little bit of complexity here. And so I'm going to speak to the Ontario experience, because this is a Lupus Ontario talk, and this is where we are presenting from. So in Ontario, Belimumab can be accessed via 2 pathways. And I would say that truly almost no patients pay out of pocket for that. And so the 2 pathways are either through the Exceptional Access Program, so that's public coverage via Trillium program in Ontario, or via private insurance through workplace, etc. And when one is applying for Belimumab via exceptional access, at this point, it is only accessible for those who have proliferative nephritis, who have more severe kidney disease for which it is approved. So without proof of that, we can't access it through that pathway. So one needs to have a confirmed diagnosis of lupus that has been refractory or resistant to conventional therapeutic strategies, which include steroids like prednisone, anti-malarial drugs, so hydroxychloroquine, and some other immunosuppressive medications. So your classics like azathioprine, mycophenolate, etc. The disease has to be active. So the SLEDAI-2K cut point is 6, which means that there needs to be evidence of active disease at the time that you're applying for it. It has to be prescribed by a specialist, and it needs to be used in combination with other conventional therapeutics. So it's not a standalone strategy. And we need to then show that it is doing what it's supposed to be doing with subsequent renewals. So the rheumatologist continues to monitor the patient to ensure that the Belimumab is doing what it's supposed to be doing. So what are the side effects? I will say that Belimumab is a really well-tolerated medication for most of the patients who have used it in my practice. But common side effects include some GI upset in the form of nausea or diarrhea, rare fevers or headache. Some patients can feel fatigued. Of course, because it suppresses one part of the immune system, there is an increased risk of certain forms of infection, respiratory infections, common cold, bronchitis, etc., being the most common among these. And then there are injection or infusion reactions. And so with the IV infusions, there can be more systemic effects like chills or rash. And for the subcutaneous form that's administered at home, there can be some redness, swelling, or some tenderness around the site of the injection, which is not a dangerous outcome, but one that patients certainly will notice and may report as well. In terms of severe but fortunately rare side effects, there can be serious infections because, of course, the immune system is suppressed not only from Belimumab, but also from some of the other medications that are being used simultaneously. An interesting severe but rare side effect is change in mood, so depression or suicidal thoughts. And it's not common, but it is something that has been reported more than with some of the other medications that we use. And so this is something that I do flag for my patients, that if they find that their mood has all of a sudden changed, evolved from their baseline when taking this medication, that's something that they should flag for me. And in the few cases that I have seen, it's been reversible back to baseline with discontinuation of the medication, which is a really interesting and I think not very well understood side effect. There are hypersensitivity reactions, which can be more severe. So these are sort of on an allergic spectrum. And this similarly with infusion reactions, the vast majority are mild, can be managed with things like acetaminophen. However, there can be more severe infusion reactions, and in the clinics where these medications are administered, the nursing staff there are very well versed in how to manage all forms of these should they arise. And then an exceptionally rare, less than 1 in a million complication for these and virtually any other immunosuppressive medication is that of something called progressive multifocal leukoencephalopathy, which is a serious brain infection caused by the JC virus, which can be quite disabling and even more rarely life-threatening. Now let's talk a little bit about Anifrolumab. So this is a newer kid on the block. It was approved in 2021, and it is given as an intravenous infusion. This is usually administered in a hospital or clinic, and the typical dosing schedule is once every 4 weeks, and each infusion takes about 30 minutes. So this is not a lengthy infusion. People come in, they leave within an hour or a little bit more than that. Generally very well tolerated, and you'll see that the cost is almost dollar for dollar the same as that of Belimumab. So side effects which are actually not unlike those for Belimumab, but with a few exceptions. Because of the immunosuppression inherent to this medication, there's risk of upper respiratory tract infection, bronchitis, of cough. An important one, and one that's unique, is that of an increased risk of shingles. And so the vaccination for shingles, the Shingrix vaccine, is recommended uniformly in advance of starting this medication. There can be infusion reactions and headaches. And on the severe but fortunately rare side of the ledger, there are serious infections. There's reactivation of certain viral illnesses. There are once again more severe hypersensitivity reactions. These mood changes, as well as PML, as mentioned with Belimumab as well. So who qualifies for Anifrolumab? So the pathway here is a little bit different. So many of the features are quite similar, but the things to point out is that it is available via exceptional access or through private payer. So that's no different. What is different is that through exceptional access, an exclusion criterion is that of active kidney disease. So you're not using Anifrolumab for patients who have nephritis as being an important aspect of the disease. So this is for non-renal lupus. You need to have the confirmation of diagnosis, once again, refractory to steroids, to hydroxychloroquine, and to immunosuppressive agents, more conventional immunosuppressive agents, and again, moderate to severe disease activity by SLEDA2K, needs to be prescribed by a specialist, and needs to be used in conjunction with other conventional lupus therapies, with ongoing monitoring being committed to by the treating rheumatologist, once again, to ensure that it's doing what it's supposed to be doing. So, you're about to start a biologic. So how does one prepare and manage? So of course, this is a collaborative approach. And so the first and foremost thing is that you need to be speaking to your rheumatologist, making sure that your questions are answered and that you feel comfortable and well-versed going in. An important thing to consider for patients of childbearing potential is consideration of pregnancy. And while there is not strong data in support of using biologics of these kinds in pregnancy, simply because the runway hasn't been very long, the track record has been excellent, and with every passing year, we see that there's been excellent success with these medications in pregnancy because they're large molecules. They're thought to be handled quite well, and really the recommendation that we give for use of biologics in pregnancy is simply that we defer any live vaccines in baby until 6 months of age. An important piece is to undergo any screening that needs to be done. So checking in advance by way of any sort of viral infections, monitoring of blood tests to see what the baseline status is. And truly, compared to some of the other medications we use, like mycophenolate or azathioprine, The lab monitoring from the perspective of looking at liver enzymes and blood counts and so on is far less of a burden with these biologics because we don't anticipate the same sorts of changes with these as we would with those other medications. Vaccinations we'll spend a little bit more time on. Suffice it to say, it's important to ensure that vaccines are up to date. They're best to get before immunosuppression is on board, but as I say to patients, having some protection conferred wherever you are right now is probably better than having none at all. And so even if it's suboptimal, it's still better to get the vaccine than not to get the vaccine if it's offered, even if you're already on immunosuppressant therapy. We want to make sure that there's thoughtfulness around infection prevention. So adopting good hygiene habits and avoiding contact with sick individuals. At Mount Sinai, where I work, we've re-implemented masking in all clinical areas just last week. And so there's, increased burden through the colder months by way of flu and RSV and COVID and all sorts of things. And so masking best practices are things that one can keep front and center and can be very helpful as an infection prevention measure. Of course, monitor for side effects. Your rheumatologist wants to know how you're doing. Even between visits, if you have concerns or if you have questions, I would say that we would uniformly encourage you to be in touch so that we can be aware and so that we can support your care in the best way possible and adapt to best suit your needs. And then come back to see us. If you're feeling great, we want to hear about it. If you're feeling poorly, we're sorry to hear about it, but we can do better. And so those follow-up visits are so important regardless of whether you're feeling well, which we hope you are, or if the medication is working less well than it should be. So these are things we need to know about. So a little bit of a sidebar about vaccinations, because this is an important strategy that you need to employ before embarking on any sort of immunosuppression, ideally, and certainly with biologics. So if you're already on immunosuppression, avoid any live vaccine. So what's a live vaccine? So a live vaccine is one that contains a weakened form of the virus or the bacteria that cause the disease, and it's designed to trigger an immune response without causing the actual illness. But because the live vaccine uses live organisms, they can pose a theoretical and a very rare but important real risk to those who are immunosuppressed that the actual infection will arise in that individual. And so the most common live vaccines in Canada, which aren't very common, so MMR is an important one because it's common, the varicella, the chickenpox vaccine, the Flumist nasal spray flu vaccine, Zostavax, which is the old form of the shingles vaccine. We don't really use that. We now use a killed version of the vaccine in Shingrix, and then the yellow fever vaccine in those who are traveling more remotely where yellow fever is an issue. So plan ahead. If live vaccines are needed, they should be given at least 4 weeks before starting Belimumab or Anifrolumab. Inactivated vaccines can be given closer to the start of the treatment or even during treatment. So inactive vaccines need not delay treatment. If it's urgent, of course, we're always balancing the risks and benefits of deferring treatment in favor of optimizing immunogenicity of vaccines. So this is something that you have to discuss with your rheumatologist. And then ensure that catch-up routine vaccines are up to date, including things like the Tdap, the hepatitis B series, consideration of HPV vaccination, and so on. Vaccinations to consider. So the flu shot. So the flu shots are now out. They're recommended annually to protect against flu. The pneumococcal vaccine is a very important one. It's typically given for seniors, but in anybody who's immunosuppressed and an adult, it is recommended that you have that on board to prevent pneumococcal disease, which can cause serious infections, not only pneumonia, but meningitis as well as sepsis. Conventionally, there was Pneumovax 23 and Prevnar 13, but the newer kid on the block is Prevnar 20, which is kind of a one and done and encompasses many of the serovars that were covered by the other two previously. COVID-19 vaccination. So I had to look at what the most recent NACI guidance has been, because there are some patients who barely have 2 COVID vaccines, some who have none, and some who are going on their 142nd one. And so the recommendation right now is for patients who are immunosuppressed to have a booster every 6 to 12 months to monitor for when new boosters are coming out, because they cover variably for former strains. And so we want to try to keep that repertoire up to date. Hepatitis B vaccination, if not boosted, tetanus, diphtheria, and pertussis. So an adult booster is required every 10 years, or if there's been an injury, a rusty piece of metal, that kind of thing, one can get a booster there as well. The meningococcal vaccine is one to consider. It protects against meningococcal disease, which is a devastating potential infection that causes meningitis. And then HPV vaccination, which has really curbed the risk of cervical cancers for those who are getting it early in life. So these are the ones to consider and to review with your rheumatologist, with your family doctor. So what should I expect? So in the first weeks after you start these medications, I think it's reasonable to expect very little. And the reason why is that it can take some time before these medications take effect. Some patients can find that within the first few doses, they start to feel an improvement, and that's wonderful. But don't be disheartened if you are not in that category, because it can take anywhere from 3 to even 6 months for these biologics to take full effect. And so your rheumatologist will likely plan follow-up around that sort of timeline. Of course, monitor for side effects between visits. And as I mentioned, reach out to your rheumatologist if there are any concerns or questions. And in summary, so we're fortunate to have numerous therapeutic strategies to treat lupus in 2024. Among these, biologics offer a targeted approach to block key pathways central to lupus pathogenesis. These biologics are generally very well tolerated, and awareness of risks and side effects associated with their use really promotes informed decision-making as you go forward on your lupus journey. So with that, I want to thank Lupus Ontario again for this opportunity to present. And I gather I can open it up for questions. And so I think I'll stop sharing. And thanks again.
Thank you very much for that extremely informative presentation. I know I learned a lot, and I see some questions that have already popped up. So I know people have been interested and engaged in the content. Just a reminder to everyone, I'm sorry I forgot to mention earlier, there is a Q&A function. Down at the bottom of your screen, you will see it looks like a speech bubble with a question mark in it. If you click on that, you can type questions in and we will be able to present those to Dr. Steiman. So we have lots of time for questions, so please dig deep. No question is silly. Throw anything you'd like to learn a little more about in there. Just a reminder though, can't provide personalized medical advice here. Okay, jump into a couple of these. The first one is a comment from Heidi. Oh, and that is, I was on Benlysta at $30,000. I guess that's even more when it was even more. That was 10 years ago. The self-injectment or the sub-Q option is a nice improvement that came out at the end of her treatment. Now she's hoping Safnello will also be able to go that route. Do you have any thoughts, or do you know if there's anything in the pipeline that might see a sub-Q delivery for Safnello?
So I think that the drug companies are alive to the benefits and the convenience of subcutaneous injection. And I think that it's something that most of the drug companies tend to try to evolve towards. And so while that's not available on the market, I think it's something to watch for.
The next question was just a confirmation about the use of Safnello or Anifrolumab, as they're the same, to confirm if it was that you could not use those with nephritis, or was it for only those with active nephritis? What was the distinction there?
Right. So I'm sorry, I don't know if I'm keeping up with where the questions are, if I'm looking in the right place. So I'm grateful for your reading these out for me. Belimumab can be used for non-renal disease or renal disease, but if you are trying to access it via exceptional access, so through public coverage, it needs to be in the context of nephritis, number one. And it is approved for the management of lupus nephritis, whereas Anifrolumab at this point is approved for non-renal, non-CNS disease.
Thank you. That clarifies. I know it was on the slide earlier, but there's so much to learn. It's easy to forget the details as they go by. Um, Another one, a shout out from a friend, Aziza. Just wondering if you could give Belimumab to a patient if they wanted to get off having to take the pill form medications such as prednisone, Imuran, or Plaquenil.
Hi, Aziza. Good to hear from you. I think the answer is a strong it depends. So the devil is always in the details with this. And as you can see, navigating access can be challenging. So you need to be able to meet the criteria that are required either through private or public payer. And I have to say that from a private payer standpoint, they often mirror those requirements that we see on the exceptional access side. So if that patient were to qualify for Belimumab or for Anifrolumab along those lines, then yes, it could be used to sort of adapt the regimen. I think the real challenge sometimes in my practice is in the patients who have been on medications and who do okay, but are interested in getting off of some of these medications, tapering down off of the prednisone, but their SLEDAI scores are actually quite good. Their serology is not active. And so using these biologics as a bridge towards steroid sparing, I think, is something that practically becomes a little bit challenging sometimes when people are doing relatively well, but on meds. So I think that may be a point for advocacy going forward. And I've mentioned as much. So, I think that the answer is a strong maybe. I'm not trying to be cagey, but I think it's very much an individual case by case sort of basis.
So then to can summarize, for now, it would probably be difficult to make the switch through the EAP based solely on the desire to just reduce prednisone, for example.
Correct.
But if you were to say not be relying on a private program and were willing to come out of pocket on the medication, that might be something that you could look at.
I mean, listen, out of pocket coverage opens doors certainly, but it's not feasible for the vast majority of people, and it's just so exceptionally cost prohibitive at this point, anyways.
Of course.
There's more flexibility certainly if you're not needing to navigate a pathway for sure.
Great. Another one. This one is I had anaphylactic reactions and hospitalization after the first two COVID vaccines and was told I could not have any vaccines of any kind unless an immunologist signed off on it first. I always feel at risk without being able to have vaccines. You seem to say everyone can get vaccines. Is that the case? It sounds like
I
a
mean,
tricky
I think
question.
I think there are always exceptions, and I think that this is where that personal individual experience comes into play. And for you, I'm sorry you've experienced that. I would say that if you've had anaphylactic reactions to COVID vaccinations, this is not something that I would be inclined to encourage you to do again, because it seems that for you, the risks may outweigh the benefits here. And you're somebody who is going to probably be more reliant on alternate strategies in terms of infection prevention, masking, hand washing to the max, and then relying on herd immunity to the extent possible, which of course I appreciate the vulnerability that you feel, but at the same time, it's something that you need to balance against the risks. And so the vast majority of people ought to get vaccines, but with exceptions such as these ones, I think this is something that you need to discuss with your immunologist, your rheumatologist, and so on, and find the balance that's right for you.
That sounds like a very tricky position to be in. Sorry to hear that you're stuck in that spot. Um, Another one, I'm wondering about how long you can take Benlysta. Is it something that you can stop taking once SLE is under control?
This is another one where I think there's a lot of art of medicine, and there are so many other questions that I would have in answering that question in terms of what other medications you're on, what you're trying to taper down off of. I think that The only thing that we take to the bank is that we like to try to maintain hydroxychloroquine to the extent possible in individuals with lupus, because we know it's a flare preventer. But if somebody's done well over a long period of time, I think our goal is typically to try to scale back very gradually, gingerly on medications to see, how safely we can do so, and to ensure that we can navigate towards as close to drug-free remission as we can. But it's a safe medication to take over
Absolutely.
the long term.
That's all the active questions we had at the moment, but we still have a fair amount of time, so maybe I could ask you a question or two. And in the meantime, I encourage others, if you've, anything you've just heard and you want to respond or get more information on, please do throw your questions in. We still have time. I was curious about when you were talking about the refractory patients and how they qualify for the biologics. I was just curious, what percentage of those patients would you say make up your practice? Is this a common phenomenon, pretty rare that people don't respond to the tried and true kind of original methods?
Yeah, it's a good question. I would say that it's a minority, but a large minority where we have to navigate. And I think that there are two factors that we always have to consider. And the first is response from the perspective of disease activity. And then the second is tolerability of medications. And I think that having these medications in our toolkits really permit for that latitude and for us to be able to practice the art of medicine instead of being very prescriptive in the very few options that we have. And so it's a boon to everybody to have options. And I would say that, most people don't necessarily need a biologic, but there's a good number in my practice that do. And I think things evolve as access changes as well, right? So it's informed by the patients who can access them as well.
It's great. So just give people an idea of sort of what the odds might be of potentially landing in that area. I was also going to ask about some of the earlier diagrams that you had up, and I noticed on there was the mTOR pathway, and then when we looked at the Euler guidelines, I didn't see it. I don't think any of the medications listed there were targeting that, like mTOR inhibitors, and I was just wondering, is there any role for those medications in treating lupus?
I think that we are really in this lupus renaissance right now, where there's so much interest. And, there's been fascinating overlap, as we'll soon see with Dr. Matsis's talk as well, in some of the therapeutics that have been sort of adapted from anything from oncology to other immunologic conditions to other forms of rheumatic diseases. And so I think the sky's the limit. I think there's a lot of interest and a lot of innovation that's evolving in the setting of these new biologics that are evolving elsewhere. So I think that anywhere that we saw in that pathway that was inherent to the either the innate or the adaptive side of the immune system may actually bear fruit. I think it's always about balancing the risks associated with fiddling with those pathways as well, right?
Absolutely. We did get another question coming in. This one, the patient's on Benlysta and low-dose prednisone, and speaking generally, is wondering, is suffering from the water retention, the general puffiness that we often see as patients taking the steroid medication. She's wondering if there's anything generally that can be done to help with that.
It's a really challenging issue. There's puffiness that can be attributable to prednisone, to nephritis potentially, to joint swelling, and the list goes on. And so I think the particulars make a difference. I think that to the extent that one is able to taper down the prednisone, we know that that can affect some benefit from the perspective of decreasing that peripheral edema that we sometimes see. Of course, management of the disease itself. And sometimes it's a slower process than anyone hopes, but steadily with improved disease control and tapered steroid, it tends to improve. But I don't have fast sort of recommendations for the day-to-day. Certainly in the setting of more severe kidney disease, sometimes a little bit of a water pill can be helpful from the perspective of comfort, but I think it really depends on the individual and the context.
Very good. That kind of gave me a follow-up question. I was just thinking that from the EAP perspective, I'm assuming that if tolerating the side effects of prednisone become problematic, that might be potential grounds for making a case for EAP. Would you find that might be sensible?
I think that, behind every EAP application on the other
Hmm.
side, there's somebody reviewing it, right? So if you can make a compelling case, and if there's steroid-associated morbidity, if there are complications associated with other medications or contraindications to their use in the first place, I always highlight those, because this isn't robotic, this is medicine, and there's nuance. And so to the extent that we can try to instill that into our applications, I think it's worthwhile to do so. That's a good question.
Great. Well, hopefully that's somewhat helpful. I know it's hard with we can all relate to the puffiness from prednisone. It's just so many of us have been there and been almost unrecognizable. Our faces, like just in our other parts, just yeah. My heart goes out to you, and I hope that you can get the prednisone dose down a little more, and we'll see some improvement there, and it'll be a good turnout. When we finished up the questions, we do have a slight bit amount of more time. So if you're typing one in now or have one last Hail Mary, please do throw it in. In the meantime, I will just start wrapping things up. But if your question comes in, we'll be sure to address it. Just wanted to take this opportunity again to give a big thank you to Roche, our sponsor for tonight. Again, it's been very educational, and that kind of support really helps put on events like these. Thank you again, Roche. Also, thank you so much, Dr. Steiman. You've given us so much to think about here, and a really excellent understanding of treatment pathways and kind of the backbone of how these applications work, and potentially pursuing these medications, what it might take. And so we really appreciate that. Do you have any last thoughts, anything else you want to share with us before we wrap up tonight?
I just want to thank you for this opportunity. I think that there's always such lovely, robust dialogue with Lupus Ontario, such an interested, passionate group. And I look forward to future opportunities to work with you all. So thank you so much.
Thank you for being here tonight. It's really great.
Thanks.
Thank you so much, Dr. Simon. We have a few minutes before we're moving to our next session. Just for hope for the future, anybody who's listening to this is there are many pharma companies who are currently doing clinical trials on other biologic medications. So what this is going to mean, which is going to be amazing for this renaissance that Dr. Simon just referenced, is that hopefully coming to market will be a bunch of other biologics. So it could be from different pharma companies. It could be different methods, like more subcutaneous options. There's a variety of things in various trials. So the future is looking quite bright for options because we are so complicated as patients, and the rheumatologists have to weigh so many things. We need some more options. Having two is incredible, but there are going to be more in the next 10 years or so coming to market. So that is very exciting for all of us.
I would say, and maybe hopefully with the additional competition, will hopefully drive some of the costs down and make these medications a little more accessible.
Wouldn't that be amazing? Yes, that would be incredible. And of course, like cost of subcutaneous, there's less cost involved of having to go to a clinic for the infusion, so they're weighing all these details together, but hopefully and maybe perhaps the more that are in market, our Ontario government might change some of our codes so that it doesn't have to require so much paperwork to be the exceptional access. It might be more available. If you are watching this from another province or another country, please be sure to check with your rheumatologist about what is available in your community, because obviously we're giving the perspective from Ontario, but we know people are watching from elsewhere. So just be sure to talk to your rheumatologist to see what are the options for accessibility for these kind of medications.
Yeah, sometimes the companies themselves will provide access to them for patients who in need who can't afford them. So there are treatments beyond, or I mean, sorry, options beyond just the typical ones available sometimes.
Mhm.